for example, how referrals can be passed across, and just how to work more effectively and communicate together as well. So if we're going to use the chat today for some Q&As as well, so if you just want to pop in the chat any emerging challenges you're experiencing for working with one or two of the other roles, or if there's any that you've not experienced personally but you kind of see coming out through your conversations, then feel free to put some things in the chat. So I'm seeing that someone's put blurred boundaries, varied expectations of what the different roles are supposed to do. That's definitely something that we'll be covering off next.
There's quite a few, Jenny. Sorry, it's Caitlin from Barnet.
Sorry,
quite a few about the roles overlapping and like who's referring in from the GP side, making them aware of who best to refer to and making appropriate referrals.
I can see someone's mentioned about how to not duplicate work as well, from a health coach in Hammersmith and Fulham. The practices not knowing who we are or what our job role is, or engaging with us. Yeah, I can see there's a lot of different things coming up, but it's mainly about understanding the different roles and making sure people in the practices can understand that as well. Oh, I can see someone's got their hand up, so if you want to come just onto mic and speak.
Hi, I'm a care coordinator in East Merton PCN. My colleagues are probably joining this meeting. We have got the 3 roles in the practice: health and wellbeing coach, social prescriber, and myself, a care coordinator. But one of the challenges that we are experiencing is not so much with how we work with each other. We do have got a good understanding of what we should be doing and how we work in our small personalized care team, but we have got more than one care coordinator, and sometimes, and I've heard that from other care coordinators, they are sharing that I just wanted to say that some of the care coordinators are saying that what's challenging is that we are very much involved in the planned care appointments for various groups of patients, and that feels like that's all we do. We are just scheduling appointments.
Okay, so we were talking about the 3 roles, and I think one of the things that I didn't get to hear what everyone was saying about the challenges, but there is definitely something around clarifying our roles within primary care. We know that obviously this has been, I mean, I've been hosting these events for link workers for the last 18 months, and it's really clear that this is a big challenge. It's been a huge challenge for link workers throughout to try and explain their role in a simple way. And obviously the link worker is not being used in the same way across London, across the UK, or even in some cases across the PCN, where they may be doing something slightly different in each of the practices. If you could just go to the next slide, Jenny. We've got the 3 different roles, and there is a very quick way of summing up how each of these roles could and should be used. So social prescribing link worker, the main focus of that role is to look at working with an individual around their social determinants of health. And these might be things that are going to potentially have an impact on their health and well-being. So we link workers will work with people that may have housing issues, they may be socially isolated, they may be a carer for somebody, and that's taking up a lot of their time. They may have employment issues. There's a whole raft of reasons that somebody might be referred into a link worker. We're seeing increasingly that people with mental health needs, it used to be quite low level mental health needs, but as that mental health services are overwhelmed, I think link workers are seeing more and more complex cases on the mental health front. But ultimately, the function of their role is to work with an individual around their social determinants of health. And they might use a number of different approaches to work with that individual, but ultimately they're looking at practical, to connect them with practical, social and emotional support within their communities, and activities that they can get involved in that maybe are going to tackle some of these social issues that they're experiencing. They are a really important bridge between primary care and the community. So we know that link workers are doing a varying amount of this, but it's obviously, there's no social prescribing without awareness of what's happening out there in the community. So it's a link worker's role to understand, to map, to know about the services, to build links with those statutory and voluntary sector services and activities that they're going to be connecting the people they're working with to. I'll let Caroline talk about health and wellbeing coaches, but we know that that's about behaviour change, and I'll let her speak a little bit more about that. The other important role, and it seems that there is a huge number of care coordinators now coming into the system across London. Their role is very much to work with patients who will benefit from support in navigating the health system and making sure that they're being connected with the right people. We know that clinicians are really busy, and people with complex, multiple issues perhaps are particularly vulnerable. They're not always going to understand what's being told to them in an appointment, or perhaps they have questions outside of their appointments. And the care coordinator can offer continuity of care. They can be a point of contact alongside busy clinicians. They also are a really important ally to these individuals who benefit from post-appointment follow-up conversations, a bit of extra support in understanding their condition, and creating a space to reflect on the choices that might be right for them. Obviously, all three of these roles sit under the personalised care agenda, and this is really about making sure that those individuals have the right support to be able to make choices that are right for them. They're going to also provide coordination and access to appropriate services. They don't duplicate what the link worker does, but they may be able to make a very quick referral. And actually, really, there's a lens through which they can be aware of the additional services that the primary care offer. If they see somebody that needs behaviour change, they may refer to a health and wellbeing coach. If they see that somebody has some really complex social issues that need unpicking, they may also refer them to a social prescriber. I think it's really important to say that care coordinators are also much more likely to be proactive in case finding. Where we see this working really well, they're working through patient lists, they're working, making proactive calls to people to understand what their needs are and think about which services or support primary care can offer that they should be connecting them with. We've also seen some really great examples where care coordinators can be the main point of contact for care homes, but this goes back to this continuity of care and being a point of contact when clinicians and receptionists, especially at the moment, are very busy. So I'll hand over to Caroline, who's going to talk a little bit about health and wellbeing coaches.
Cool, thanks Leanna. Hope everyone can hear me, because I know that there has been lots of internet problems, so well, just let me know if you can't. I will assume that everyone can. So I'm Caroline, and I am a health and wellbeing coach in East Merton Primary Care Network, and I'm also the health and wellbeing coach mentor for London, so that's providing peer support to health and wellbeing coaches in London. So I'll just give you a bit of an overview about what health and wellbeing coaches do, so that we can hopefully try to clarify where some of those boundaries are. I know that was one of the problems that was coming up, or one of the challenges that was coming up in the chat box earlier. So health and wellbeing coaching is really focused on helping patients to change their behaviour in order to improve their physical or their mental health. So we know that patients, or many patients, don't understand clinical information given to them. And we also know that many long-term conditions can be worsened by detrimental health behaviours. So all of these factors point towards the need for more behaviour change focused conversations. And that is where a health and wellbeing coach comes in. So health and wellbeing coaching is a partnership between the patient and the coach. So it's a slightly different relationship to that of doctor and patient, so similar to link workers really. So we have much longer appointments and we can really understand what matters to the patient and help them to formulate a goal for what they want to achieve for their health. So it's very much forward or future looking. We can help them to understand what barriers might be getting in their way, so what's kind of stopped them from reaching their goal in the past, and help them to circumnavigate them. We can help them to break their goals down into small, manageable chunks, so they can start to determine what actions or what changes they want to make to take them towards their goal. We have quite regular appointments with them to help keep the patient accountable and help to keep them on track. And through this process, we help the patients to gain the knowledge, the skills, and the confidence to become active participants in their care. So it's really about helping them to become empowered to take control of their health, and that will then help to increase activation and hopefully mean that the patient can be more self-supported. I guess the ideal end result is that the patient builds some long-term habits that will help to improve their health over the long term. So really kind of focusing on sustainability, really. In terms of referrals, I mean, the referrals for health and wellbeing coaches will be different depending on which PCN or which practice the health and wellbeing coach is in. But just in terms of the patients that I see a lot of patients for obesity and weight loss. And actually, a lot of the time, what patients say is when they come in for obesity, they are patients that have potentially suffered with this for most of their lives. And even just after one appointment, that most patients say that it feels really helpful to have just sat down and really had a long conversation and spoken about everything really honestly and openly. And that helps them to feel kind of lighter, really, because a lot of the time, you know, it can be, patients feel quite judged, so making sure that it's a really kind of non-judgmental space, and yeah, that can really help. I see a lot of patients with long-term conditions. Obviously, obesity can be associated with long-term conditions such as diabetes, cardiovascular disease, hypertension. I see a lot of patients with mental health challenges such as depression and anxiety. I see a few for smoking cessation or cutting down alcohol, that sort of thing. So patients who I don't see, so I don't see children on their own. I see some patients as families, so where they've all got the same health goal. I'll see the parents and the child together, but I don't see children on their own. I don't see patients who are actively suicidal. Obviously, they need much more specialised care. And then I don't see patients who do not want to make a change, so people who aren't motivated, who don't want to make a change, so they obviously wouldn't be appropriate for a health and wellbeing coach either. And then obviously people who need more specialised medical help need to be referred on to the appropriate person as well. So I've been working as a health and wellbeing coach for about a year now, and yeah, we've had some really great results. That's not to say all patients have great results. Obviously, there's some patients who don't engage with coaching very well, but the majority do. So yeah, so it's been very, very productive, and I think we've got a relatively robust way of working. As Agnieszka was saying earlier, we've got the care coordinator and a health and wellbeing, and a social prescriber in the practice as well, and we've kind of found our way working with each other as well. So yeah, that's been my experience so far. I don't know, are we asking if anyone's got any questions about health and wellbeing coaching? Please feel free to put your hand up or put it in the chat.
Yeah, I think this would be a good time actually to hear from the audience whether what we've been talking about has been useful, and obviously any clarifying questions that people have about these three roles. Feel free to unmute yourself if you feel like it would be easier or quicker to ask a question.
Hi, Caroline.
Hiya.
Hello. What I wanted to ask was, how have you found the staff in your practice about awareness of your role and properly utilising and supporting you? So, you know, thinking, hang on, this would be perfect for the health and wellbeing coach, or sorry, a bit clumsily put, but.
Yeah, I completely understand what you mean, and I've certainly heard those challenges from health and wellbeing coaches before. I think one of the things that really helps, and I know this isn't possible for lots of health and wellbeing coaches, is actually being based in the practice. So I don't work virtually. So I'm kind of making sure that I'm really embedded here, going to lots of meetings or holding lots of events. So we had a kind of health and wellbeing coach opening ceremony where, you know, we snipped a ribbon and we invited everyone to it. And actually, there's some really big advocates here of personalised care and the 3 personalised care roles. So even before I started, actually, I think a lot of that was me being lucky, but there's lots of advocates here for the personalised care role. So they'd already done a really good job of communicating to everyone what the 3 roles did. But that's not to say it doesn't need more. So whenever people start, you know, new roles start or new people start in the practice, they'll always sit in with some of my clinics to understand what I do. And similarly, when I started, I sat in lots of other people's clinics as well to kind of explain what I did and, you know, who might be referred on to me and where I could help. So I tried to understand the challenges that the different GPs were facing and kind of tried to explain how I might help with particular challenges that they were facing. So it's really just making sure that you're kind of included in all of the meetings that are happening and explaining again and again and again what you do.
So being really proactive sounds like you know that it's that sort of thing, but also I think with the thing that you said earlier that you're in practice, that's not always possible for some practices with room space and with COVID. So there might be, I guess, a call for a mix of face-to-face, and some patients won't want face-to-face perhaps as well. Do you find that?
Not many, actually, to be honest. I mean, there was there was a few right at the beginning of the year that I saw over video, or a couple that I saw that I spoke to on the phone, but nearly everyone I see face to face. And I think, yeah, no, not many people have said that they don't want to come in. So, yeah.
I think this is one of we actually ran an event earlier in the year around building allies within your primary care network. And there are some really useful slides on there. It's focused at social prescribing, but I think a lot of it will be relevant, and perhaps thinking about it, it would be useful to develop something for the other 2 roles as well, about who within the surgery are the key people to be making sure that you're developing relationships with. And when you're, you know, creating documents like the one that we've got up on screen now, thinking about who you're going to circulate that to, who might you be getting your referrals from, who might be setting the strategy within your surgeries or within your primary care network about the types of people that you're going to be working with. We're going to hear from somebody later about proactive population health management and how these 3 roles can be really useful in thinking about which people, what your local, what are the needs of your local population, and how might these 3 roles be really instrumental in giving personalised care to groups of people that may not normally engage with primary care networks or primary care services, or who may struggle to. I think Polly is asking some really good question. About the care coordinator role and how perhaps they are being used as admin and reception work, and maybe that there is a confusion about what the purpose of that role is. And actually, Ali Hassas, who is the care coordinator regional mentor for London and has started up a monthly session to bring together all care coordinators, we put this question to him, and he actually was saying, you know, the thing that's important about the care coordinator role is that they have to be really embedded with the clinical team. They should be turning up to the MDT meetings and working alongside the clinicians to make sure that the contact with the patients is seamless. And without that, it can become a basic admin role, and it is just definitely not a basic admin role. A receptionist, obviously, their role is clear. They should be taking calls coming in from outside. A care coordinator, if anything, should be making proactive calls out. So taking cohorts of patients. We'll hear in a bit more detail from Janie about how their coordinators are the proactive case finders within their primary care network, and are the people going out and contacting cohorts according to their sort of demographic or their health needs. Does that answer your question, Polly?
Sorry, took a while to work out where the unmute button was. Yeah, it did in large part. I think it also, I mean, I don't know where I've heard this before, but kind of a resistance maybe from practice managers feeling like the role is de-skilling existing admin staff. So not so much that the care coordinator would do admin work, but that they feel we've already got someone doing that. Why do we need someone that we don't know, that we haven't selected through our own interview process, coming in and doing some part that's similar to that?
It's a really good question, and I think, you know, in a way, if somebody is coming into somebody's practice, it would be, in an ideal world, the primary care network would have engaged that practice to make sure that they, you know, have had some kind of a say in who's been recruited. I suppose that's not always going to be the case, and maybe this is a question that Janie can look at when she's giving her presentation. I'm just thinking, are there any other questions? If there are any other questions specific to the roles, perhaps they could go into the chat, and myself and Caroline, and we've got some link workers, some really good link workers and care coordinators, health and wellbeing coaches in the room. Let's have that conversation in the chat. Jenny is, I believe Janie is the next person to speak. So perhaps if you could move the slide on. Janie.
Yeah, so hello everybody, I'm Janie Wyke. I'm one of the PCN managers in Barnsley and I lead on personalised care. Don't move to the next slide, please. So how I started out, so in September 2020, I started my role as a social prescriber, a link worker. In Barnsley, we were setting up a social prescribing service to work with young people. This service was new. We set it up in September. We started off with 6 link workers. It's done absolutely fantastic. So we started off, so I started developing that service. 6 months later, I was invited to apply for the PCM manager's job, which I then got. And this has helped me develop strong personalised care skills. So I've got a real passion for personalised care, and I think my background as a social prescriber really helped me have an excellent understanding of personalised care, the individual's needs, and also what the practices needs as well. So if you want to move on. So I'll just give you a quick overview of how Barnsley works. So Barnsley is slightly different to most PCNs. So in Barnsley, every GP practice is signed up to be part of it, so that we've got 32 practices, all part of one big PCN. We've got a population of 260,000. How we manage it, to make it more manageable, what we do is we split it into 6 neighbourhoods, and each neighbourhood's got a clinical director. So Barnsley PCN is hosted by Barnsley Healthcare Federation. They already had some excellent success with some other services that we run. So we've run a service that's called ARRS. It's an extended hours service. They also run an out of hours service, and we also provide training for all GPs and practice staff within our PCN. So if you want to move to the next slide, please. So Barnsley's got a massive personalised care team. So what we've started off with 6 social prescribers, 1 assigned to each neighbourhood. That has now expanded to 8. That service has been doing so well. We're now aligning with the adult social prescribing service. So we're increasing our number of social prescribers up to just nearly 20. So that's we're just in the process of that happening. So the social prescribers all work agile. So each GP practice know who their social prescribers are, and they have constant contact, but they don't actually work in the GP practice. We've then across Barnsley got 35 full-time equivalent care coordinators. So these care coordinators, we found it best to embed them into the practices. So they all work in practices with the practice team. All the practice staff know exactly who they are. They're working there day to day. Occasionally there is a little bit of agile working, but we try to stick to the care coordinators being in the practices so that the practices are aware of who they are and what they do. We also have 17 full-time equivalent health and wellbeing coaches across Barnsley. So how we work that is the health and wellbeing coaches, they are assigned to practices and they will see patients in that practice. Because our health and wellbeing coaches have been so successful, we've then had to employ extra who work as sort of floating health and wellbeing coaches. So pick up any referrals that So it's an overflow sort of system, because we get that many referrals in to the health and wellbeing coaches. We had to get some sort of extra support in. So if you want to go to the next slide for me. So getting these roles to work together, this is the hardest part of personalised care team. So what I had to do is making sure to start with that the roles understand what part they play in the team and what job roles they do. So with the job roles, there were a slight crossover between all of them. So what we did is we stripped the roles back, and each person had their own job roles. We made sure there were no crossover, so there were no duplication, and every role understands what their job part is and what everybody else's is. So it worked. We found that were the best way for people to work as a team. So like I've mentioned, the care coordinators, they work in practice, they identify the needs of the patient. The social prescribers work agile, they cover a neighbourhood each, and our health and wellbeing coaches are assigned to practices and see patients within the practices in Barnsley. So if you want to go to the next slide, please. So the contribution to PCN, so all the 3 additional roles have massive contributions to how Barnsley achieves covering both the impact and investment fund and the specifications. So with the early cancer diagnosis, in Barnsley, all our care coordinators are the first point of contact for anybody who's been referred on a 2-week wait. So in Barnsley, we have a digital system that's called See the Signs. Any patient that's referred in to a 2-week wait is put on See the Signs, and the care coordinator is responsible for following that patient through to either a cancer diagnosis or referring them on. Obviously, if they've come to us with problems, if they've not got cancer, there's still something going on there. So if a patient's referred on a 2-week wait, our care coordinators know exactly at which point in the referral process they're in. They also contact the patients a couple of days after the patient's been into practice to make sure that there's no questions, make sure that there's nothing that they want to ask, because obviously when somebody comes into practice and they're referred on a 2-week wait, it throws them out a bit. So the care coordinators are the people that are there for that person to answer questions for that person. If that person just wants somebody to reassure them that their referral's gone in, it's the care coordinator they'll contact. If the patient's pushing towards the 2-week wait and it's going to go past that, it's the care coordinator that's on the phone to Barnsley Hospital. Why isn't this patient being seen yet? It's the care coordinator that makes sure all the bloods have been sent with the referral, so we don't ever breach potentially we won't breach the 2-week referrals. The work that the health and wellbeing coaches we do with the cancer, they usually step in a living beyond cancer. When a patient's had cancer, you usually find after they've recovered a few months later, they'll need that little bit of support to get themselves back motivated, back into normal life. So that's where the health and wellbeing coaches come in. All our health and wellbeing coaches, our care coordinators and our social prescribers are all trained in behavioural insights. So they deal with patients who maybe don't want to come in for the smears, they don't want to come in don't want to do the fit tests. So they've all had training, so every patient contact counts. So care coordinators are responsible for contacting the patients who haven't turned up for the smear, haven't completed the fit test. They'll contact them, they've had training, they know how to have these awkward conversations. The quality group. The care coordinators are working with GPs in practice to validate that register, to make sure that every patient with severe mental illness is registered properly and gets that support. They're invited back for their health checks. The care coordinator contacts everybody on the severe mental health register, invites them in for an annual health check. If that patient's got reservations to coming in, our care coordinators are trained on how to have them conversations. Anticipatory care, so we've got some trials going on. This hasn't come in yet, but we're already on it in Barnsley. Our care coordinators are identifying patients who are at risk of becoming frail, contacting them and running through a series of questions. If any issues are highlighted, they're then referring them on to either the occupational therapists, or they're referring them to social prescribers if necessary, or if they can help themselves, they're helping them themselves. So if you say it's an elderly gentleman that's forever coming into the practice, his wife's just passed away, he's basically lonely, the care coordinators are just giving him that phone call once a week. Are you okay? Do you need anything? It just stops that patient phoning up, coming in. Again, personalised care, the care coordinators do you just want to go back a slide? I think we might have missed a few bits on there. Yeah, the personalised care, the care coordinators are working with patients, the social prescribers are, and the health and wellbeing coaches are. Impact and investment fund. So the annual health checks, the care coordinators are getting people in for them. Full vaccines, again, they are. Referring to social prescribing, so the care coordinators are case finding for the social prescribers and the health and wellbeing coaches. Reducing A&E attendance, so BIOS being on top of anticipatory care, hopefully that's had an effect on our A&E attendance. People who were at risk of becoming frail have got that little bit of support before it comes to a point where they're having accidents, they're falling over. Development of personalised care plans, we've talked about that already. So the care coordinators are all trained on that, and they do all the personalised care plans in Barnsley. We're at 100%, we're there already. So the delivery of ward rounds. So our care coordinators do all set up all the ward rounds, they facilitate it all, they arrange all the MDT meetings, they get everybody to the relevant appointments, relevant meetings, they get everybody that should be there, they coordinate all that. Any actions that need taken away, so if the patient needs referring to memory clinic, it's our care coordinators that do that. It frees the GP's time up, it frees the community matrons time up. If that person in a MDT meeting would benefit from support from a social prescriber or a health and wellbeing coach, it's the care coordinators that make that onward referral to our health and wellbeing coaches, our social prescribers. All three roles work together. They all know exactly what we have regular personalised care meetings. They all know exactly what the other role's doing, how to contact them, when their care coordinator, when their health and wellbeing coach is away, who's stepping in for them. I think that's the key. Communication. That's how we've managed to get our personalised care team so good in Barnsley. We've got excellent communication between all the three roles. So if you want to move on to the next slide. Collaboration, not duplication. So the most important part of making these three role works is education of practice staff. So like you've mentioned, there may be care coordinators out there, they're doing admin work. It's because the practices don't understand what these roles are for. So what we did in Barnsley, we had a massive push. We went out, myself and the other PCN manager went out, we sat down with practice managers, we sat down with GPs, reception staff, right, how can we help? What do you want these roles to do? What do we want to achieve? So that's the main part, education of all staff. In Barnsley, we have a PCM meeting every month. So at that meeting, we discuss all the additional roles. We highlight where things are going well, things are going wrong. We have regular team meetings for all the personalised care staff, so we can do shared learning and reflection. And again, like I mentioned, we've got clear defined job descriptions for each role, so everybody knows what they should be doing. Some shared learning we've done, so the care coordinators, what we do with each role, every month we take a case study to the PCN, so where a care coordinator's done good work. For example, one of our care coordinators has been handed this frequent attender, and this woman's phoned up every day for the last 2 or 3 months to the reception team. The reception team, she's got a different person every time she's phoned up. It's been handed to the care coordinator. Within a week of being handed to the care coordinator, the care coordinators identified that this patient's got showing signs of dementia. Nobody had highlighted that before. The family lived away. This patient's now been referred for some help with a dementia. It's been diagnosed, and that would never have been picked up on if that patient just kept phoning a different reception and getting a different receptionist every time. It's just little things like that that we do shared learning, and it across our PCN, it highlights what excellent work our additional roles are doing, and what great results we're getting out there. I think that just about covers everything we're doing in Barnsley. So if anybody has any questions for me. I'm just looking in the chat. Our care coordinators don't do home visits. They go into the care homes with on the ward rounds. They don't do home visits. So it has been known that our care coordinators will meet patients if that patient's weary about coming into practice. They've met patients in parks like link workers would, but we don't expect them to do home visits. Our care coordinators have all had training on care plans. They've all had training on dealing with people with learning disabilities and people with severe mental illness. What things do you highlight when training practice staff? Basically, I sit down and I go through the
looking at the chat. I don't think I have much of the chat coming through.
We go through the job descriptions of the roles, highlight how these roles can help. All 32 practices are now on board, so it's sort of, we've gone past that now. They all fully understand all the roles.
I'm just thinking.
Is there anything else anybody wants to ask before I leave it there?
Yeah, sorry, can you hear me okay? Is Caitlin?
I can, yeah.
Are all the roles employed by the PCN?
Yes, yes, all roles are employed by the PCN. How we do it in Barnsley is when a practice wants the role, the PCN manager and maybe the practice manager or the GP from the practice will interview. They know what will fit in their team better, and we've found that the roles, it gets the roles embedded in the practices better if the GPs or the practice managers have actually interviewed them themselves and made the choice. So that's how we get it to work in Barnsley.
It was really, really interesting. And I think she said, let's go to Laura next.
So what I was saying basically is, but pretty similar to Jenny actually, we work as a coalition of PCN. So we are a population of around 230,000 patients, and we are organized around neighborhoods, around PCNs, 4 neighborhoods. So how are we using the ARRS roles in some way? These personalized ARRS roles is just
so wonderful to hear how
various ways, but specifically I'm going to talk about how are we focusing on health inequalities. We've had the same challenges as everyone, I think, and what we've tried to be is very easy when explaining out the roles to our practice teams and also to the people, to the communities. So specifically focusing social prescribers' role in social determinants of health. So when we created the referral criteria, we actually tick on the box of care needs, housing needs, isolation, very mild mental health needs, etc., etc. Whereas with the health coaches, we go specifically for behavior change. I always say to patients, I present them personalized. We have here Shaween, for example, who is the one who works with me in Wellington. She's going to help you to take little steps and prioritize little actions so that you help yourself to become healthier, things like that. And actually, they are both in practices. We started with the social prescribers a year ago now, and now at the end of October we started including the health coaches as well. So we have them in practices in 4 of the PCNs, but the next step with the care coordinators now, exactly what's been said so far, we're trying to get their really good help in proactive case finding and also following up on patients that may have a bit more of difficulty engaging with the services, so that we make sure that we provide this personalized care. So where are we going now? Because actually I want to share a bit more the vision very briefly so that you see where we're going in Sutton. What our vision is as a coalition of PCNs basically is to make a really strong move to proactive preventative care, personalized care, and to have a specific focus in filling the gaps, so basically to try and tackle health inequalities. And we found the personalized ARRS roles really helpful in working as a team, not just with the practices, but as a team in our neighborhood model. So the neighborhood model is the personalized, as I call it, the personalized structure of the neighborhood health system. We're trying to move from the NHS to a neighborhood health service, integrating with other stakeholders in the community, voluntary sector, social care, mental health, so that we wrap around care around neighborhoods. So we are bringing the neighborhoods as a campus of health creation, campus of community assets. And the ARRS roles, the health coaches, the social prescribers, and the care coordinators are starting to work around this neighborhood model. We are towards patient personalized care, so with the same specific roles, but actually much more focused on the neighborhood level. So we do have regular meetings now, social prescribers, health coaches, and later on we're integrating as well the care coordinators, who have been so far helping much more with the proactive case finding, vaccination, COVID vaccination, and also as well they've been helping with our community virtual ward, MDTs, and I'm not going to repeat all the good things that Jenny was saying around this role, because actually it's really good to see that we have loads of similarities in how we are using them. And now we are trying to start merging these kind of personalized teams in the neighborhood, working with other partners, working with community residents, with our health champions, and how with social care, etc., etc. So those are the next steps coming. So I think these, in terms of how, because I think there are a few questions around how are we integrating and how are we using the roles to tackle health inequalities. Basically, we've always, all the work and all the service we are creating with these personalized ARRS roles are with the lens of prioritizing to the areas that of higher social injustice, so that this is key for the care coordinators. For example, we are risk stratifying patients, starting to do that, and they are the ones who are actually proactively finding identifying people that we have to work with because of obviously higher risks, not just medical problems, but also social determinants of health, which actually is the most of unemployment, ethnicity, and all these other little very important factors that define or determine their health, the impact on their health. So we are starting to build the neighborhood platforms in which actually these ARRS roles work together with all the professionals and community services, social care, and starting again to build what we call community teams, or we are starting to call community outreach teams. So we definitely need to go out into the community, because most of the well, I don't really like to say it this way, but the hard to reach people, they don't come to us. So we really need to go out, and we're starting to bring, specifically making relationships with people like homelessness, people like the travelers, so communities like the travelers, specific ethnicities and specific communities in areas of high social injustice. And the health coaches and the social prescribers with the care coordinators are starting to go out and make those relationships, so that we can actually bring intervention out to where they are proactively. So I know that was very brief. I was just wanting to add the lens from the health inequalities thing, because I think there is a lot of good work that is already being said, and I didn't really want to double that. I hope that helps a bit, but we still are basically working on making relationships with the community, making team building basically with the 3 ARRS roles, and with all the members in the community. And it's actually really exciting, because there is really good work with COVID vaccination happening at the moment, and that we really hope we continue with lifestyle education and proactive healthcare basically. So that was more or less from me what I wanted to share. More than happy, sorry, because this was clashing with another meeting, so I really, it's really interesting what's been said, but I'll need to to leave. So if there is any quick questions, and there is time, more than happy to answer. I'm more than happy to pick any other, and I'll be guided by you. I don't know if Liana, Jenny, they have connection.
I'm not sure either of them have connection, but there was a question in the chat which was, how are you defining the communities with higher health inequalities to target them?
Really good question, because we still are improving, I think, in how we define that. I think at the moment we've identified, so with the fantastic work that our NHS engagement lead he's been doing for ages, we do specifically know groups of communities of, like, for example, the homelessness. We're working with the travelers as well, but specifically areas like we have one of the most deprived areas in England, actually here, the Barnsley estate, that when we basically use a bit of linked data, the ones of high rates of unemployment, of drug use. We've been working with the police as well to identify specifically domestic violence. So those areas in which with data we pick on this specific information are the ones that we are starting to work with, and actually, funny enough, are the ones that are a bit more, as we know, difficult to reach. So that's a real, that's actually how we are working, and by going out in the community, really, because we do have data, but we do have our health champions. There are 67 people, volunteers in the community that have been doing an amazing work during COVID vaccination, identifying people, trying to help with health education as well. And we've actually set up like a ward of champions that are now we are working with them in how we can build on this co-production model with all the services from the PCNs that we are delivering. So they bring people straight away that even sometimes we can't capture with data. So yeah, that's more or less how we're starting to do that.
Thank you, Laura. That was really interesting, especially about the health champions. That was, yeah, very enlightening. Thank you.
My pleasure. Thank you for having me here. I'll need to rush. Thank you.
Okay, bye, Laura.
Bye.
Thank you. So I think next we're going over to Barnet, to Caitlin and Louise.
Yeah, perfect. Thank you very much. With Barnet, so I'm the social prescribing link worker manager, and with me today I have Louise, who's our social prescriber from PCN2. We have a team of 18 social prescribers in Barnet, and this year we've been doing a lot more collab working with our care coordinator training lead, and between herself, Rafif, and me, we've been sort of discussing how the two roles for care coordinators and social prescribers can be utilised best in the practices, and how they can also be a support to each other. As you sort of all kind of said today, there's sort of a difference of remote working and some people being in the practices, and this does make it difficult to have that sort of daily communication and connection. And we've sort of tried to facilitate support for the two roles as more and more care coordinators have been coming into Barnet in particular. And one of our PCNs, so PCN2, we have trialled a small pilot of creating a sort of protected time, one slot per week over a 6-week period, and that could be up to sort of 30 minutes or 15 minutes for both the care coordinator and the social prescriber of that practice to discuss cases. And in this particular PCN, the care coordinators have been building their caseloads for supporting patients with either long-term conditions or sort of care navigation. And we found it to be sort of a really positive space or protected time where the two roles can discuss either complex cases they have on their caseloads, discuss patients who may benefit from either of the role support as well. And what we did is we did a 3-week review and a 6-week review of this, and found it to be really useful, like I said. just for the 2 roles to be able to connect and support. And then from that, we've, as more and more health and wellbeing coaches are now coming into Barnet, we've now sort of developed this further to create a quarterly meeting that will be happening across Barnet. And we had our first one earlier this month in November for all of the personalised care roles. So that's all social prescribers, all care coordinators and all health wellbeing coaches in Barnet to come together to essentially have a 2-hour meeting slot where we look at developing them further. So actually looking into their own wellbeing and their challenges and concerns, and have a sort of a space for that to be able to support them in their roles, and also increase their awareness of what each other do, how they can best support and work together in their primary care networks. And so we had our first one in November where we focused particularly on mental health for them and their mental health and wellbeing at work as they deal with complex cases and difficult caseloads. And then from the first meeting, we've done a feedback form looking at what we can focus in on next. And we really want to home in on working on how we can improve their partnership working and support their challenges and complications within their day-to-day working. And we'll be doing those every quarter from now on, with, again, really, really positive feedback from the 3 roles, just due to I suppose that feeling of sometimes a lack of support and lack of knowledge from the primary care network teams on their particular role description and how they can be best used. So we're trying to really sort of offer that space and that support for the 3 roles in particular, and to help them connect and meet as a team within their own primary care networks as well. And so I'm just going to pass over to Louise, who's our social prescriber from PCN2, and she can just tell you a little bit more about the pilot and how she's experienced that.
Hi all. So the pilot was really great. Meeting with the care coordinators is very insightful, what they do and what we do. So it was nice to meet each other, albeit via Teams, but we met each other and it was great to discuss sort of what they do and then what we do and how we can work together to accomplish the goals that people would like to reach. So I have 4 care coordinators for the 4 practices that I deal with in PCN2, and we try and reach out at least once or twice a month via email, because as we know, everyone is busy. But when the pilot was going, it was great to just connect and find out what challenges each one of us was up to. And I still get messages now from surgeries, from the care coordinators at the various surgeries, of if I can help with something or if they can help me. And it really is a teamwork. It really, really is. So it's good to just compare stories, find out what works well, what doesn't, and how we can change it. So it was a really positive pilot that took place, and we are still in touch now, and we probably email, like I said, once or twice a month. If we need each other before that, we know that we can just reach out.
So yeah, so as we sort of go into the next year, and we're going to be hoping to run these across our so we have 7 primary care networks in Barnet, so we're hoping to run these across the next 6, and so we're sort of we're presenting this pilot and seeing who else would be interested. The main challenge we have in Barnet is the care coordinator roles have been sort of really pushed this year, and some primary care networks are utilising their care coordinators for slightly different sort of areas of interest, and so we're sort of trying to work with the clinical directors and their sort of interest for their care coordinators on that. So yeah, so we're hoping that we'll be able to sort of repeat this across the primary care networks to get the best support and the best outcomes. Thank you very much.
So I caught the end of your presentation, and I know a bit about your example as well, and I think there was something about this that really struck me. You know, this is very much the link workers and those that are working on the front line. to a certain extent, you're at the mercy of leadership within the primary care networks and the practices that you're working in. But we've heard some really lovely examples today of where link workers, people that are working on the front line, have seen an opportunity to connect with each other. And I would urge people to go back to the session that we did earlier in the year around developing allies. I think I put the link in the chat, because there's some good suggestions in there about, you know, if you're struggling, if you're feeling like you're working in isolation, to think about who you might be able to reach out to do what these guys have done in their PCN and start up these regular meetings with the care coordinators, so that they can then go to leadership within the surgery or the PCN to say, this is how we think it should work and this is why. And hopefully, I missed Laura's presentation, but I know that you know, it's great to hear from a CD who's super passionate about the value of these roles when they're being used correctly. There was a question actually, which I think would be a really nice one for you to, if we go into the Q&A now, but one that came to us prior to the event, Caitlin, is what do you do? What would you advise as somebody that understands the various bits of the system to link workers, care coordinators or health and wellbeing coaches who are working in a bit of a silo? Perhaps there aren't other roles around in their PCN yet. What should they be doing?
Yeah, I think it's really, really challenging, because I do honestly empathise with a lot of the you know, roles that are very much isolated, or, you know, just don't know where to start with their communication. The first thing I think is always best to do is, you know, obviously with the practice managers, try to get invited to practice meetings, and you will meet more and more staff members. And particularly with that, if you have a training hub that you are able to get connected in with, there's great links through there as well of getting support, and finding out more about who's around, essentially. So they should have a list of all the recruited. And yeah, from you know, from what we've done is really just simply, you know, my role only came in sort of 8 months after I started for managing the service, and I think there needs to be a real push for that, of having some supervision offered, whether that is just a peer support element and getting involved there more locally, or honing in on clinical supervision as well, because I do know that is still an issue and not being provided by PCNs sort of in different areas. So yeah, really raising that. And also I think just the support of these sessions and raising issues, we, you know, in local boroughs, you can always try to get support from the people around in your local sort of area as well, even if they're not in your borough. Do try to get connected with the people that are around you.
Yeah, that's an incredibly good suggestion. And I think now that the Health and Wellbeing Coach Network and the Care Coordinator Networks are up and running, definitely echo the recommendation to try and join those sessions so that you can meet other people doing similar roles to yours. I think the other thing to say, and this is something that as we're starting to go out into the system and try and identify areas where all three of these roles are working together, and we're seeing examples of where link workers, especially in the very small PCNs, or where there's maybe 5 or 6 link workers across a larger PCN, maybe they're focused on a particular surgery, we're seeing people do a bit of a blended role. So they might be connecting with the community, but they may also be doing some of the advocacy and support to the more vulnerable patients that are connecting with the surgery on a regular basis, and perhaps using some coaching techniques with some people that might need some behaviour change longer term. What I always recommend, I don't think it's bad that people are doing these blended roles until you're starting to become really effective and you're generating lots of referrals. I think it's really important to try and be clear which hat you're wearing at different times, and be able to have that conversation with your PCN if you feel that there is need for added resource for any one of those 3 hats. So if you feel that there's a particularly, you know, huge number of vulnerable people that your surgery is supporting, perhaps help them have that, do some thinking around whether or not they might utilise a care coordinator to support you, or if you've got, you know, a cohort of particularly large cohort of obese patients that are looking to manage their weight, perhaps there's value in bringing in some time of a health and wellbeing coach to work alongside you. Any other questions from, thank you, Caitlin, that was really helpful. And I just also wanted to say there's so many examples across London of people doing interesting stuff with this. Many people are at the beginning of their journey and thinking about how the three roles work together. We are really keen to identify more examples of where this is working and start to build some case studies. It may even be just a bit of an idea that you have at the moment. Get in touch and talk to us about it, because we can document the progress over the coming months. Examples of care coordinators and link workers working together for surgeries. I think there's some really lovely examples of care coordinators making the proactive calls and identifying where social prescribing and offering social prescribing to individuals that they think may have some social issues. I put that question out to the room. Anybody got some good examples of where they're working well alongside their care coordinators?
Well, I'm a care coordinator, but we do refer to social prescribers. It works really well because we are calling pre-diabetes or weight management patients. But obviously, sometimes we're the first person the patient might have spoken to from the practice or on behalf of the practice. And those patients want to talk, and then it can become very aware they need additional help, because you'll call them about one thing and then an issue will emerge, whether it's anxiety or housing, and that's where we can use the social prescribers, and that's worked really well. We've got, you know, as Caitlin said, we know what their roles are, so it's nice to feel able to refer that on, knowing you can actually give them a real proper solution. It feels very good. It works well, I feel.
It's a fab example. We've got a hand up. Feel free to unmute yourself and speak.
I have got a really good example of care coordinator and health and wellbeing coach working together at our PCN. We have recently had video group consultations and face-to-face group consultations with a population who was suffering with post-COVID syndrome. And so care coordinator, myself, has facilitated the session, and Caroline, who's our health and wellbeing coach, was present alongside a GP and was offering that additional wellbeing input. And that worked really, really well. There's some good outcomes for the patients. We had referrals, appointments booked for patients. There was the element of peer support. And obviously now we are thinking to invite different groups of population who could benefit from that kind of group consultation platform, and perhaps include a social prescriber in the discussion, but it would have to obviously be maybe a different topic where they could benefit from the advice and knowledge they have. But that worked really well in our surgery.
What a really lovely example. Can you just remind us what's your name and where are you? I feel like I'm on
my name is Agnieszka. I work with Caroline and Nicole at Wideway.
Brilliant. And just quickly, what's the distinction between your role and Caroline as the health and wellbeing coach? How have you defined the roles in that activity?
I facilitated the event, so I did obviously the initial the search for patients who could benefit from that meeting. I've connected with all patients, so I had a bit of a background information about their health issues. I knew what they were struggling in terms of post-COVID syndrome. I've sent the meeting invite and just generally facilitated the whole meeting. I've spoken to Caroline briefly and a GP who both were present at the meeting about what kind of issues the patients are having. So they were a little bit prepared for that. And what maybe, and then they have sort of, Caroline has, based on the group we had, prepared a couple of slides on the things that she thought patients could benefit the most in that particular group. And doctor obviously offered that one-to-one medical input, knowing again what sort of patients we are dealing with, what kind of problems they have. We were able to make proper decisions for patients at the end, where some of them have had to speed up the booking their annual review, or maybe needed a different kind of follow-up based on the discussions that happened on the day. But we were 3 of us, a GP and health and wellbeing coach and myself, at that meeting, working well together.
Brilliant. It's really great. We've got a lovely comment from Kemi in the chat about the care coordinator attending the MDT meetings with the link worker, and they're getting together to discuss certain patients, and so the care coordinator who's doing home visits actually is getting a much more in-depth picture of the patient and can really support the wider work. I think there's some really lovely examples here, and I hope this is the start of the conversation for all of us to come together and sort of start to share some of these examples. Emma's put a question in the chat. Would you mind unmuting yourself, Emma, to ask your question? She's not.
Hello.
There she is, yeah.
Yeah, I just wondered, because just sometimes the care coordinators might make a referral to, say, social services or or the physios or ATs, and that's also something that social prescribers would do. So I just wondered, there always seems to be a slight overlap in that both care coordinators and social prescribers all signpost and make referrals. So I just wondered, is there specifically any division, or is it just something that each sort of PCN needs to sort out between them?
Can you give an example of where of the overlap, the types of onward referral or signposting you think a care coordinator and a link worker might do?
Yeah, so something like with social services. So maybe if somebody needed to have a care needs assessment, that's something a care coordinator might refer to social services, or it could be something that a social prescriber would do.
We have been repeated discussions about this in our peer support, and I don't know if there's anybody here who has joined one of these discussions about whether or not it's a link worker's job to refer to social services. I think in this situation, my answer would be both of those roles. Whoever is in contact with the patient and who has the time may think about making those referrals. It's also important to say that in some cases, neither the link worker nor the care coordinator would make that referral. It would be the GP. I'm interested to hear from the room though. Who's got thoughts on that?
I'm a social prescriber, and I do the referrals to adult services. So the GP, when they send a referral, and it normally sort of says carer support, and then in the box of add additional information, it always says a referral to social services would be appreciated, which is always fun. But I tend to do the adult referrals. I tend to do that. And I don't know if the care coordinator does, if I'm honest. I don't even ask, I just do it, because obviously I can see on EMIS if it's already been done. So I just do it. I don't do physio, physio referrals.
Anybody that feels strongly as to whether or not this is a link worker role or a care coordinator versus a care coordinator role?
Hi, it's Caitlin. I think it's really important to remember that referring somebody to social prescribing is because that individual needs support, or like further or has further complications or complex issues. So if it's just the one-off need, I would argue that that wouldn't be the right thing to send through to a social prescriber if it was just for that referral to be made. Whereas if the individual needed a bit of coaching or a bit of support planning and had further needs, that would be when a social prescriber would also do that referral, but also unpick other issues. Whereas a care coordinator might be in the better position to be able to just do even if it was a one-off referral, if the GP felt like it was more part of their condition or care plan. So I hope that helps. If you're going to refer to social prescribing, it should be because that individual has maybe one or two needs, or maybe a bit more complex and just needs a bit of help with self-management. And that would be where I'd argue.
Yeah, that the issues are the social determinants. The referral comes from the social prescriber because that individual has got social issues that they need addressing or support in addressing, and they would go to a care coordinator if they have multiple long-term health conditions and are connected in with the health service in a more concerted way. I think I would preface this also though with the link worker and the care coordinator may do this because they have extra time and can really spend a long time on these applications. But if you ever feel like you're in a situation where you feel like you don't have enough information or you don't have the skills to be able to complete one of those referrals and you need support or additional training to pick up the phone either to your local social services or try and find somebody within the surgery to raise that you need extra support with this, because it can be, you know, referrals may not always go through if the right information is not on there. So it is quite important to make sure if you're having the responsibility for making these referrals that you feel confident and comfortable doing that.
Can I just say something?
Yes, Alev.
Yeah. Hi. I had a case recently. I've received a referral from the GP for adult social care, and I contacted the adult social care team and they asked me to refer that case back to the GP because the client was known to the adult social care team. So they said it should come, the referral should come through the practice-based mental health team. So I couldn't make that referral because it should have come from the GP. So
yeah, and there will be those cases. I think the other thing to say is that if somebody has a social worker, they might not need a social prescriber. Somebody is receiving that level of focused support. It's possible that they, you know, that the function of the social worker, the social prescriber is maybe being picked up by a social worker also. We've gone down a very specific route to, I think we've come to the end of the session. I think it's clear that there's a lot of stuff still to discover about how these three roles can work together, and perhaps there'd be value in revisiting this topic perhaps in 3 or 6 months' time, just with some other examples of what's happening across London. To say these events run every month. The next session is going to be on is at the beginning of January, and it's going to be focused on, the theme is going to be supporting people with dementia and the people caring for people with dementia. We have a couple of open sessions which we haven't set a theme for. So if you're a link worker, a social prescribing link worker out there, and you've got an idea for something that you think is a bit of a challenge and you'd like to hear what how other people across London are tackling it, or maybe would like to share some of the innovative work that you're doing, then please do get in touch with some ideas for what future sessions could look like. We will be sharing the recording and some of the Q&A and the resources and slides that we've discussed today. They'll go up on our website, but we'll send an email out to nudge you once that's been updated. It'll also go in the newsletter, which is going out tomorrow. So please keep an eye out for that as well. But thank you so much to all of our speakers today for your patience with all of our tech issues, to Jenny for organising today's session, and yeah, for all of you for joining and being so generous with your comments and chat in the session, throughout the session. So thank you very much, and hope to see you next month.